Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Abdullah Aljumaa, and today I'm joined by someone very familiar, my brother, my study partner, and honestly, the person who steals all my tea.
I don't steal them, I borrow them permanently. But hey everyone, I'm excited to break down today's episode because we're talking about a high yield topic common bacterial and fungal skin infections.
Yes, this is one of those topics where you might think it's just staph, it's just strep. But then suddenly you're asked to differentiate bullous impetigo from staphylococcal scalded skin syndrome, or cellulitis from gout, or toxic epidermal necrolysis.
Exactly. That's why in today's episode, we're taking you through it step by step. And by the end of it, you'll be one step closer to becoming a dermatologist, if that's what you want. Anyway,
Before we begin breaking down the different bacterial infections one by one, it's important to take a step back and understand the bigger picture. Why do skin infections develop in the first place? The skin is supposed to be a strong protective barrier. So, how does bacteria manage to bypass it?
that's a great starting point. Even though the skin is a physical barrier, it's also a living ecosystem, home to hundreds of species of bacteria, fungi, and viruses. Together, they make up what we call the cutaneous microbiota. This microbiota isn't random. It's organized into Cutibacterium species that dominate the sebaceous or oily areas, while Staphylococcus and Corynebacterium thrive in moist areas like the axilla and groin. These organisms aren't harmful. In fact, they are protective.
So, under normal circumstances, these microorganisms actually help us prevent infections?
Exactly. Problems arise when the balance is disrupted or the skin barrier is breached. Anything that breaks the integrity of the skin can create an entry point for pathogenic bacteria. So think of any minor trauma like insect bites, scratching and eczema, shaving, friction, pre-existing skin conditions like scabies or dermatitis. You name it. Once that barrier is compromised, bacteria can invade, and depending on how deep they go, we see different clinical presentations.
Right, and that's a key theme in today's episode. The depth of infection determines the type of disease we see.
Exactly. That's why, as you'll see during this episode, we divide skin infection based on the skin depth affected. Superficial infections are things like impetigo and eczema, while deeper infections include erysipelas and cellulitis. There is also a level of life-threatening depth as seen in necrotizing fasciitis, which reaches the deep fascia surrounding muscles. Infections that are confined to the hair follicles cause follicular infections like folliculitis, furuncle, or carbuncle.
Those are some interesting names.
I know, right? I'm curious to know how they even came up with that. Once we finish with the bacterial diseases, we will transition into the common fungal infections, including dermatophytes and Candida.
Perfect. With that overview in mind, let's start our journey at the superficial level with one of the most recognizable infections in pediatrics, impetigo. Mohammed, picture this. A child comes in with itchy spots around the mouth, and by the next morning, they've turned into those classic honey colored crusts.
That's almost a textbook case of non-bullous impetigo. It usually occurs over an area with a small break in the skin, like an insect bite, scratching an eczema, or simple trauma. Once that barrier opens, bacteria such as Staphylococcus aureus or group A strep take advantage and colonize the superficial epidermis.
And that's where those golden crusts come from?
Exactly. They are the dried exudate from the infection. Even if you wipe them off, they come right back because the bacteria are still active in the superficial layers.
People always get confused between non-bullous and bullous impetigo. What makes bullous impetigo different?
Bullous impetigo is special because it's driven by toxins, not just bacterial invasion. Certain strains of Staph aureus produce exfoliative toxins, exfoliative toxin A and exfoliative toxin B, that target smoglin 1, which normally hold the superficial epidermal cells together.
So when those toxins break the smoglin 1, the skin layers separate?
Exactly. And that separation forms those flaccid, easily ruptured bullae. And here's something people mix up. In bullous impetigo, the toxins act locally. So if you culture the fluid inside the bullae, it will grow Staph aureus.
Which is very different from staphylococcal scalded skin syndrome. Because in staphylococcal scalded skin syndrome, the toxins circulate systemically and the bullae don't actually contain the organism.
Okay, so staphylococcal scalded skin syndrome and bullous impetigo have the same toxin family, but completely different mechanism of spread. That's one of the key distinguishing points.
Before we wrap up impetigo, There is a very important complication related to strep biogens infection.
If the impetigo is caused by group A strep, there's a risk of post-streptococcal glomerulonephritis. And interestingly, treating the impetigo early on with antibiotics doesn't prevent that complication. It could still happen even if you catch it and treat it early.
And keep another important point in mind that impetigo, even with streptococcus, is not associated with rheumatic fever.
Exactly.
Alright, before we continue, quick question for you, Ahmed, and for everyone listening. What makes bullous impetigo form those flaccid blisters in the first place?
The exfoliative toxins A and B, which cleave desmoglein 1.
Exactly. That toxin-mediated split is the whole reason the bullae form. Alright, let's continue down our ladder of skin infections. We just wrapped up impetigo, which stays on the surface. Now we move slightly deeper into the hair follicles. So, let's imagine a patient who comes in after shaving with multiple tiny pustules around the hair follicles on the beard line. What does that immediately make you think of?
That's probably folliculitis. It's essentially inflammation of the hair follicle, usually caused by Staphylococcus aureus invading that tiny pocket. It tends to happen in areas with friction, sweating, shaving, or occlusion.
And unlike impetigo, folliculitis is centered specifically on the follicle itself, right?
Exactly. The pustule actually forms around the follicular opening. It's usually mild, often itchy, and tends to be self limited unless the infection extends deeper.
Which brings us to the next stage. When it stops being just folliculitis, how do we know it's progressing into something deeper, like a furuncle?
A furuncle or boil develops when the infection extends past the superficial part of the follicle into the deeper dermis. It becomes painful, firm, and tender. Instead of multiple tiny pustules, you now have a single larger inflamed nodule.
So folliculitis is more like a bunch of tiny pustules, while a furuncle is one angry, deeper nodule.
Exactly, and it keeps going. When multiple furuncles merge together and create interconnecting abscesses with multiple drainage points, that becomes a carbuncle. These are larger, more severe, and usually come with systemic symptoms like fever or malaise.
I also remember certain areas being more prone, especially the nape of the neck or areas with thick, tightly packed hair follicles.
Right, and that's where we also start thinking about risk factors. Things like diabetes, obesity, friction from clothing, or anything causing moisture accumulation. And another important clinical association comes up, which is that recurrent furunculosis always raises suspicion for MRSA, especially community acquired strains.
And of course, management shifts too. Folliculitis can be treated conservatively, but once you get into furuncles and carbuncles, incision and drainage becomes the mainstay.
Exactly. Antibiotics alone often don't penetrate a mature abscess in furuncle and carbuncle, so drainage is essential.
Great. So folliculitis is the entry point. Furuncles are the deeper, painful extension, and carbuncles are the coalescing clusters that can cause systemic symptoms. Before we go any deeper, let's go for a practice question. When you see recurrent furuncles in a patient, which specific pathogen should immediately come to mind?
That would be MRSA, especially community acquired strains.
Alright, Muhammad. Now we're stepping into one of the more dramatic skin conditions. To start off, imagine a young child, maybe a toddler, who is irritable with diffuse redness and tenderness of the skin, and areas where the skin seems to peel off with just mild pressure. What's happening here?
This picture fits perfectly with Staph's scalded skin syndrome. It's a toxin mediated condition caused by certain strains of Staphylococcus aureus. These bacteria release exfoliative toxins that travel through the bloodstream and target a very specific protein in the skin called desmoglein 1. When this protein is disrupted, the topmost layers of the epidermis separate, leading to widespread blistering and peeling that looks like a burn.
And what makes this especially tricky is that the skin often looks much worse than the underlying infection site. The source might be something tiny, a small area of colonization, but the toxins spread everywhere.
Exactly, and that's why you often see this condition in infants and younger children. Their kidneys aren't fully mature, so they can't clear the toxin efficiently. Adults can get it too, but it usually requires significant immunosuppression or poor renal function.
As we said, If you culture the blisters in staphylococcal scalded skin syndrome, they will not have any bacteria because the toxin is moving throughout the body from some other source. But the bacteria is not found in the blister itself.
Yes, in Staphylococcus scalded skin syndrome, the blisters are sterile because the problem isn't a local infection, but rather a systemic one. Unlike bullous impetigo, which has a local toxin effect, and the bullae will contain the bacteria.
That's a high yield difference. Another feature of staphylococcal scalded skin syndrome is how easily the skin peels. The slightest friction can cause the epidermis to lift away.
Right, that's the Nichols key sign, and in Staphylococcal scalded skin syndrome, it tends to be strongly positive. Even gentle pressure can cause the superficial layer to shear off because the connection between the epidermal cells has been weakened by the toxin.
And clinically, these kids look uncomfortable. The skin is tender, they are often febrile, and dehydration becomes a concern because the skin barrier is compromised.
Exactly. Fluid loss, temperature dysregulation, and secondary infections are the big concerns. It's one of those conditions that requires careful supportive management.
Before we move on, let's solve a practice question. Why are infants more susceptible to staphylococcal scalded skin syndrome compared to older children and adults?
Because their kidneys are immature and can't clear the circulating exfoliative toxins effectively.
Exactly. That decreased toxin clearance keeps the toxin running around for a longer period of time. Now let's shift to a condition that can present very suddenly and progress extremely fast. To set the stage, imagine a patient who comes in with a high fever, a diffuse red rash that looks almost like a sunburn, as well as low blood pressure and signs of multi organ involvement. What's going on with this patient?
This presentation is suspicious for toxic shock syndrome, or TSS. It's another toxin mediated condition, but unlike staphylococcal scalded skin syndrome, which affects the skin, toxic shock syndrome affects the entire body. Certain strains of Staphylococcus aureus and Streptococcus pyogenes release superantigen toxins. These toxins bypass the normal immune activation pathway and directly trigger massive T cell activation, leading to a cytokine storm. That's why patients present with fever, rash, hypotension, and systemic dysfunction all at once.
And the rash is really characteristic. It has that diffuse, bright red appearance, and later on, you often see peeling of the skin on the palms and soles.
Exactly. The desquamation usually happens about 1 to 2 weeks after the initial symptoms. Another key feature is the multi-system involvement like the gastrointestinal symptoms, renal issues, liver enzyme elevations, and altered mental status. It really can hit almost every organ.
And is there a difference between the staph and strep virgins in terms of cultures?
Yes, in staphylococcal toxic shock syndrome, the bacteria aren't necessarily found in the bloodstream. The toxins are the main drivers. But in streptococcal toxic shock syndrome, blood cultures are much more likely to be positive because the bacteria themselves are invasive.
That's why it's important to have a high index of suspicion for toxic shock syndrome and treat it early on, especially when you see a patient who's rapidly deteriorating with a rash and hypotension. It's not one of those conditions you can afford to miss or delay.
Definitely, early recognition and aggressive supportive care, along with treating the underlying source and targeting the toxin producing bacteria, are key to improving outcomes.
How about another practice question? What feature of the toxin makes toxic shock syndrome so severe?
It's the superantigen activity, meaning it activates a massive proportion of T cells all at once, leading to uncontrolled cytokine release.
Exactly. That's what drives the sudden systemic collapse we see. Alright, Mohammed. Let's move into a childhood classic, one of those infections that shows up with a very recognizable combination of findings. I want you to imagine a child coming in with a sore throat, fever, and a rash that feels like sandpaper when you run your hand over it. What condition does that instantly bring to mind?
That description fits scarlet fever perfectly. It's caused by group A streptococcus, the same organism responsible for strep throat. But in this case, the bacteria release erythrogenic or pyrogenic toxins that trigger the rash and other characteristic findings.
And this rash really does have a distinct texture. When you touch it, it's not smooth, it's rough, almost like fine sandpaper, especially on the trunk.
Exactly, and the rash usually starts on the upper chest and neck, then spreads to the rest of the body. Another classic feature of scarlet fever is Bastia's lines, which are those linear areas of deeper redness in the flexural folds. like the antecubital fossa and the groin, so those lines are just extra red.
And of course, we can't forget the tongue findings, because this is a very memorable sign.
Yes, the tongue goes through phases. Initially, it can have a white coating with prominent red papillae, the so called white strawberry tongue. Later, the coating peels off and you get the bright red strawberry tongue.
Now, clinically, these kids look sick but not toxic the way they might with something like toxic shock syndrome. And after several days, you get that peeling phase, especially on the hands and feet.
Right, that squamation phase can last for weeks. And something important, scarlet fever can have complications. The big one is acute glomerulonephritis, just like we saw in impetigo, because the strep strains involved can be nephrogenic. Even though rheumatic fever is associated with strep throat, scarlet fever itself doesn't change that risk. Rheumatic fever risk is still based on treating pharyngitis.
Good point. So the rash in scarlet fever is a toxin effect, but the complications come from the immune response to the bacteria or the bacteria themselves. Let's solve another practice question to test our listeners. What do we call those deeper red lines that show up in the skin folds of patients with scarlet fever?
Those are Bastiat's lines, darker erythema seen in flexural creases.
Exactly. And with that, we're ready to move a little deeper into the skin. Let's talk about two infections every clinician must distinguish. Picture a patient walking into the ER with a red, swollen, hot leg. What's a possible infectious cause of this presentation?
That immediately raises concern for cellulitis. It's an infection involving the deep dermis and subcutaneous tissue, usually caused by Streptococcus pyogenes or Staphylococcus aureus. The area becomes warm, tender, swollen, and the borders are often L defined because the infection diffuses through the deeper tissue planes.
Right. And keep in mind, the redness alone isn't enough. Not everything red, hot, and swollen is cellulitis.
Exactly. Conditions like gout, contact dermatitis, or even chemical irritation can mimic cellulitis. The key is in the story, the location, the systemic features, and the borders. And remember, blood cultures are often negative in uncomplicated cellulitis.
Now let's contrast this with erysipelas, which looks similar but behaves differently.
Erysipelas is a more superficial infection involving the upper dermis and the lymphatic vessels. Because of that, it has sharply demarcated borders and can cause a more dramatic raised, bright red appearance. And it's usually caused by group A streptococci.
And clinically, erysipelas tends to have more lymphatic involvement, right? That characteristic swelling and the well defined edges.
Exactly. You often see it on the face or the lower legs. The key difference is the depth of involvement, the superficial erysipelas versus the deeper cellulitis.
Alright, let's test our listeners again. What feature helps you differentiate erysipelas from cellulitis?
Well demarcated, raised borders seen in classic erysipelas is a big clue.
Exactly. Great. Okay, now time for something more serious. Imagine a middle aged man coming into the ER with redness on his thigh. At first glance, it looks like cellulitis, nothing too dramatic. But then you examine him more carefully. He's sweating, pale, and says the pain is so severe. He can't even touch the bed. The redness hasn't changed much since yesterday, but his pain has skyrocketed. What are we thinking of?
That scenario should raise immediate concern for necrotizing fasciitis. The single biggest red flag is exactly what you described, pain out of proportion to the skin findings. Early on, the skin may not look alarming, but deep in the fascia, the infection is spreading fast.
And as it progresses, things get much worse very quickly.
Exactly. You may see hemorrhagic bullae, skin discoloration, crepitus if there's gas production, and signs of systemic toxicity like fever, hypertension, and confusion. Imaging may show gas in the soft tissue, but honestly, this is a clinical diagnosis. You don't wait for imaging if you're too suspicious.
And the treatment is straightforward but aggressive.
Right, urgent surgical debridement plus broad spectrum antibiotics. Delay is the enemy here.
I think we should go for another practice question before we move on. What is the classic early clue that should make you think of necrotizing fasciitis?
Severe pain out of proportion to the exam findings.
Exactly. It's a very important sign. It can save a life. Alright, Mohammed. We've covered the major bacterial infections, from the superficial impetigo all the way down to necrotizing fasciitis. Now, before we dive into the next group of skin infections, let's take a moment to shift gears. Not every rash or skin infection is bacterial. It could also be fungal. Fungi play a huge role in dermatology.
Absolutely. Fungal infections tend to behave differently from bacterial ones. Instead of invading deep tissue, many of them target keratinized structures, the skin, hair, and the nails, and they thrive in warm, humid environments. We usually divide them into two major groups: dermatophytes, which cause the classic tinea infections, and Candida, which prefer moist, occluded areas and anatomical folds.
Perfect. So, in the next segment, we'll start with the dermatophytes, also known as the tinea infections, which are named based on their location on the body. Let's walk through them. Imagine a patient walks into the clinic complaining of an itchy rash that's been slowly spreading. They say it started small. They thought it would go away, but instead it's been expanding. The rash is dry, a little scaly, and they notice the border looks more active than the center. Now, based on this alone, we may suspect tinea, but we need to figure out where on the body it is, because the location tells us which type of tinea we're dealing with.
Yes, exactly. When you see a rash with an advancing scaly border, you're already thinking of a dermatophyte infection. Next step is looking at the location.
Alright, let's walk through a few possibilities. Same patient, same rash pattern, but each time I'll place it in a different location, and you tell us what it most likely is.
Sure, let's do it.
Scenario 1. The rash is between the toes, especially between the fourth and fifth toes. It's itchy, the skin is peeling, and the patient mentions they work long shifts in shoes that make their feet sweaty. What does that sound like?
That's classic tinea pedis or athlete's foot. Between the toes, involvement, scaling, itching, and exposure to warm, moist environments all point straight to that.
Perfect. Now let's move the same rash to a different place. What if the patient says the rash is in their groin? Itchy, sharply bordered, spreading onto the inner thighs but sparing the scrotum.
That's tinea crus. The groin is full of heat and moisture, which makes it an ideal environment for dermatophytes. And that spares the scrotum detail is a classic clue.
Good. Now let's put the rash on the trunk, maybe the abdomen or the arm. The lesion is circular, with central clearing and a raised scaly border.
That would be tinea corporis, the classic ringworm. The ring shape with a central clearing is a big giveaway.
Now let's move to the hands. Suppose there is a dry, scaly thickening on the palm with accentuation of the skin creases.
That's tinea manium. And fun fact, a lot of people have tinea pedis and tinea manium at the same time, the 2 feet, 1 hand pattern.
Next location, the scalp. A child presents with patchy hair loss and broken off hairs that look like black dots.
That's tinea capitis, and it's especially common in school-aged kids. If it becomes more inflammatory, it can form a boggy mass called a carrion.
Last one, a man with a tender, inflammatory rash on his beard area, with hair that pulls out easily.
That's tinea barbae. The beard area gets involved, often from direct contact with animals or contaminated surfaces.
So even though all of these are dermatophytes, it really comes down to geography. The location dictates the name. Before we move on, it's time for another question. When diagnosing any of these tinea infections, from pedis to capitis, where should we take the scraping from?
Always from the advancing scaly border. That's where the fungus is most active, not in the center.
Exactly. That's the trick to getting an accurate diagnosis. Alright, with dermatophytes explained, let's shift briefly to the other major fungal category, Candida, which looks and behaves completely differently. Imagine a patient who comes in complaining of a red, itchy rash in a warm, moist area of the body. They say it's been getting worse, not better, but they've noticed tiny spots appearing around the main rash.
She has Candida infection. Candida loves moist, occluded, warm environments. So anytime you hear rash in a fold, Candida jumps high on the list. And that detail you mentioned, the tiny spots around the main rash, those are satellite lesions, one of the most recognizable features of Candida infections.
Candida can cause several different conditions depending on the location affected. So let's start placing this rash in different locations and see what it turns into. Same pattern, different spots, just like we did with the dermatophytes. The first scenario is when the rash is in the groin or between large skin folds, especially in someone who's overweight, diabetic, or exposed to humidity.
That would be Candida intertrigo, the classic fiery red patches with satellite, papules, or pustules around the edges. It's very common in folds like the groin, inframammary areas, or axilla.
Perfect. Now the same rash, but this time it's in a diaper area on an infant. The parents say it started after an episode of diarrhea and hasn't improved with regular diaper creams.
That's diaper candidiasis. The key clue here is that the candida does not spare the skin folds. Regular earthen diaper rash usually spares the folds, but candida loves them, and again, you'll see those satellite pustules.
Great point. Now, what if the rash is between the fingers, especially in someone whose hands sweat a lot or stay wet for long periods?
That's erosio interdigitalis blastomycetica, which sounds dramatic, but it just means candida between the fingers or toes, hence the name interdigitalis. You'll see white macerated skin with red moist patches around it, again with satellite lesions.
Alright, let's shift locations again. Suppose the patient has white plaques inside the mouth that scrape off and leave a red, sometimes bleeding surface. What does that sound like?
That's oral thrush, oropharyngeal candidiasis. It's very common in infants, patients using inhaled steroids, people on antibiotics, or those who are immunocompromised. The plaque scraping test is a key characteristic because scraping of leukoplakia, for example, won't make it bleed.
And to complete this picture, Candida infections often have clear risk factors. Things like diabetes, obesity, steroid use, antibiotics, high humidity, or immunosuppression.
Exactly. Anything that disrupts the normal skin barrier, normal flora, or immune regulation can tip the balance in the favor of candida.
Great! Let's do our last practice question for the day. What simple feature helps you instantly differentiate Candida intertrigo from other rashes in the skin folds?
Other than the fact that candida loves skin folds, a pretty classic feature for candida infections is the satellite lesions, small papule or pustules just outside the main red patch.
Exactly. If you see satellites, think Candida. Alright, Mohammed. Before we close, let's give everyone a rapid fire recap of the entire episode.
Perfect. Starting at the surface with impetigo, it can be bullous or non-bullous. The non-bullous type needs a break in the skin and gives you the honey-colored crusts, while the bullous impetigo forms flaccid blisters because of exfoliative toxins that act locally.
A key difference between bullous impetigo and staphylococcal scalded skin syndrome is that bullous impetigo bullae contains Staph aureus, while in staphylococcal scalded skin syndrome the blisters are sterile.
Exactly. Then we dropped into the follicles. First, there's folliculitis, which stays superficial, and when it invades deeper, it becomes a furuncle, and it turns into a carbuncle when multiple furuncles merge.
And whenever those keep coming back, especially as boils in clusters, think MRSA.
Perfect. Then we move to staph scalded skin syndrome, the toxin-mediated condition in infants where exfoliative toxins circulate systemically and cause widespread skin peeling with a positive Nikolsky sign, which means that the top layer of the skin can be peeled away from the lower layers with a slight rubbing.
After that, we talked about toxic shock syndrome, where superantigen toxins trigger a massive cytokine storm, leading to fever, rash, hypotension, and multi organ involvement.
Then came scarlet fever, the strep-produced toxin causing a sandpaper rash, fasciitis lines, and the classic strawberry tongue.
After that, we compared cellulitis versus erysipelas. Cellulitis goes deep with ill defined borders, while erysipelas is superficial with sharply demarcated edges.
And for the most serious infection, necrotizing fasciitis, the biggest early clue is severe pain out of proportion to the exam.
Then we switched to fungi, starting with the dermatophytes, also known as the tinea infections. Same organism group, but a different name depending on the location.
And the main diagnostic tool for tinea was scraping from advancing scaly border, where the fungi are the most active.
Finally, we wrapped up with Candida, especially the bright red patches in moist areas with those satellite lesions, the key feature that you shouldn't forget. And with that, we've reached the end of today's episode. If you stayed with us until now, You've covered a huge chunk of high yield material.
Absolutely.
Thank you, Mohammed, for guiding us through it.
Thanks for having me, Abdullah. Have a good one.
Thank you all for tuning into PodBites. See you in the next episode. So, under normal circumstances, these micro and carbuncles are the هاي الجملة الصعبة. Great. So في الأغلب
This picture fits perfectly with the staph scalded skin syndrome, or SSSS. It's a toxin-mediated condition. صح ما له داعي. استغفر الله.
تاني
أبويا.
حلوة وحكاية
الله يعينها لجود عم تسمع صوت نشاز. Right, that's the Nikolsky sign. And in Staphylococcus scalded skin syndrome, the superficial layer to shear off because the connection between the epidermal cells has been weakened by the toxin. صح؟
Why are infants more susceptible? Susceptible.
اضرب ليه.
كنتك ليه وثواني
طيب،
ثواني
يلا.
محمد.
مستحيل.